So coming to the next part, GI surgery. This may be the last part for abdomen. GI surgery. What are the important things? Now this is about abdominal pain. Abdominal is considered common cause of hospital admission. Very common cause of abdominal pain in adults. So this is 35% of the pain is non-specific. There is no any specific. This is called as functional pain. There may be some any other reason non-functional, non-specific pain. This is highest. Then appendicitis is second common, intestinal obstruction is third common. Then urology, gallstone, colonic, abdominal trauma, and all other. Different causes of abdominal, how to reach the diagnosis. Previously well solid knowledge. You should understand. Previously well solid knowledge has to be there to rule out the cause. History is important. Examination and lastly investigation. Different causes are extra abdominal, maybe something else, chest in or something else. They may lead to different causes. Then the causes like GIT, gastrointestinal tract, stomach, small bowel, colonic, spleen, liver, pancreas. So among GIT, stomach, small bowel, colonic, spleen, and liver, pancreas. Then renal causes, genital and vascular causes. So this is important for 9 quadrants of the abdomen. Pain as per the quadrant and what you are suspecting. So right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. This is umbilical or you can call as periumbilical, right lumbar, left lumbar, epigastric, supra. So pain, any pain in epigastric region. So it may be cardiac, biliary, pancreas, vascular, GI. Acute coronary syndrome, myocardial infarction, biliary, colitis, cholecystitis, pancreas, pancreatitis, vascular, aortic aneurysm, dissection, GI. Right upper quadrant pain is moreover it's related with the liver, gallbladder and all this. Pulmonary lower pneumonia, biliary, cholecystitis, colitis, hepatic, renal, GI, duodenitis, duodenal ulcer. Right lumbar, this is on the back side. This is going on the back side. Maybe aortic aneurysm, dissection, that is retroperitoneal. So lumbar pain most of the time is because of retroperitoneal. Kidneys are in the retroperitoneal. Colitis is also there. Pyelonephritis, nephrolithiasis, sauce abscess. Right lower quadrant, or you can call it as the right lower iliac fossa. Appendicitis is the commonest. Cecal obstruction, ileitis, diverticulitis, Crohn's disease, epididymal orchitis from testis going up, testicular torsion, ureteric colic coming from above. So these are the right quadrant pain. And in females, uterus is there in the center, ovaries are there on the both sides. So torsion of the ovary, then any pathology with the tubes, then hernia, inguinal hernia, all these may lead to right lower quadrant. So right lower is very important. Most of the diseases are right lower. So similarly, if you go for left lower, diverticulitis is the commonest cause on left lower quadrant. Ulcerative Crohn's, like right, and the rest of the GI on gynec and like side. So left lumbar is again for the kidneys, ureteric and all these. Left upper quadrant, the pain is maybe because of cardiac, pulmonary, pancreas, splenic, GI, renal. So acute coronary syndrome, myocardial infarction, myocarditis, they may have pulmonary lower pneumonia, pancreatitis, tail of pancreas, splenic fracture and all this. So this is about the 9 quadrants and pain. Right iliac fossa pain. Now we will discuss acute abdomen in females and so right iliac fossa pain, appendicitis, second most common other than functional. Migratory pain. Initially it's periumbilical, then localized to the right iliac fossa. The periumbilical is because of stretching of the peritoneum, and that is referred to the T10. Then when there is inflammation of the visceral peritoneum, it is localized to right iliac fossa. Low grade fever, anorexia is to be there. Vomiting once or twice may be marked. Diarrhea is rare. Pelvic hypertension may cause diarrhea. Evidence of localized right iliac fossa tenderness and rebound tenderness. Right iliac fossa tenderness and rebound tenderness. Rosings is the obturator Rosing sign. Compress on the left side, you get pain. Obturator sign is internal sausage sign. These are the different signs. Inflammatory markers are increased. CBC is increased TLC. Urine analysis may show mild increase in WBC count. Ultrasonography in usually in females and other pathology. CT is decision older age. Treatment option is appendectomy use, lens in females and gridirons males. Laparoscopic apnea preferred in females and old age. Patients with perfect apnea require extensive abdominal lavage is required. Appendicular mass without pituitary may require broad spectrum antibiotics. Other causes of right iliac fossa pain is mesenteric adenitis, mostly affect the children. If history of viral fever, high temperature than those in appendicitis, higher temperature, local manifestation, antibiotics has to be given. Meckel's diverticulitis is similar to the 2% of population to with gastritis. Crohn's disease characterized by terminal ileitis in this. Divertical disease, cecal diverticuli may have some sort of a incarcerated right inguinal hernia may have severe abdominal pain on the right side iliac fossa. Bowel perforation sometimes may lead to right iliac fossa pain. Gynecological disorder, torsion of the ovaries or ectopic pregnancy, salpingitis may use. Ureteric colic may have right iliac fossa. These are the many common pains. In females, what are the specific different metal shimmers? This is usually cyclic pain. So it settles in 20 to 43 hours, usually during rupture of the follicle. So that is around 13 to 14 days of the mid cycle. CBC in everything may be normal, free fluid may mild, is conservative treatment is physiological stress. Torsion of the ovaries, sudden onset of deep colicky pain is there. Associated with vomiting and distress, patient vaginal examination is tenderness, sonography will prove, laparoscopy and remote diagnostic. Ectopic gestation, history of pregnancy has to be there, childbearing age is there, then present an emergency and rupture of the impending ruptures, open tubular ruptures may sudden onset abdominal pain, discharge there, beta HCG is elevated, and USG shows no interest in pregnancy. Laparoscopy or laparotomy has to be done. Salpingotomy is usually needed. Pelvic inflammatory disease is inflammation of lower abdominal pain, pain as a vaginal delivery, discharge there, dysuria is there, beta HCG is elevated, CBC is increased, so counts the medical treatment is the treatment. Fitz-Hughes-Curtis syndrome is disseminated infection of chlamydia. Chlamydial infection, PID together with the prehepatic inflammation, subsequent adhesion formation. Abdominal USG is free fluid, high vaginal swabs have to be taken, may show evidence of sexually transmitted disease, medically managed by doxycycline. Endometriosis, chronic abdominal pain is there, 25% other patient. Remaining 50% may have menstrual irregularity, infertility history, complex disease, there are pelvic adhesions may be found in this. Ultrasound laparoscopy is then usually managed medically. So other causes of acute abdominal pain, these are the major rupture aortic aneurysm, sudden onset of radiating to the back, patient may collapse endotomically, patients are hemodynamically. Investigate clinical picture. Investigation, if those are stable, CT scans to be done, and perforated pepticles are usually in the history of upper abdominal pain, sudden onset of pain, generalized abdominal pain, patient complaint of right lower quadrant pain, by examination peritonitis, chest X-ray, erect may show gas and diaphragm, CT scan is diagnostic to laparoscopy or laparotomy has to be done. Intestinal obstruction, all this will be discussed later. General condition leading to abdominal pain, sickle cell crisis, vasoconstrictive or occlusive crisis. Vaso-occlusive crisis, vessels, severe abdominal pain. Confused with appendicitis, this is differentiated with informed human child is sickle or anemic. Nephrotic syndrome causes nephrotic syndrome, high risk of septicemia and peritonitis, streptococcal pneumonia, features of nephrotic syndrome. So coming to the hernias, it is protrusion of the tissues on the organs, identification according to the site, indirect inguinal, direct inguinal, femoral. So this protrusion of the organ from the site. So indirect, direct and femoral, there are three different types. Indirect hernia versus direct hernia. You can see this is the inferior epictic vessels, it should be lateral, coming from lateral side. This is the deep ring, this is superficial ring, from deep ring it medially you get this inferior epigastric vessels, and direct hernia is basically you get this is the deep ring, this is a superficial ring, so here is the medial side, this is the point, this is the lateral side. So from the vessels, if it is coming lateral to the vessel, it is indirect, and coming medial is the direct. Passes through the interlingual, outside through external young male lateral. So this is the direct, medial and above. It is always medial above this medial and lateral. So through the Hasselbeck's triangle is direct, and this through the deep ring to the inguinal ring. So here the vessel, the hernia is vessel is on the medial side. Paraumbilical hernia, condition of the childhood. Lineal spigeal hernia lies below internal and external oblique hernia, external oblique vessels. This is the spigeal hernia. Lies between the internal and external oblique at the level of arcuate line. Lumbar hernia adds to the petit triangle, which is bounded by the cilia crest inferiorly, external oblique laterally, and latissimus medially. Obturate hernia is internal hernia, incisional hernia, Ogdale and Morgagni hernia. Little's hernia, where the Michel's diverticulum is coming through it. Amylin's hernia, where appendix is coming. Richer's hernia is part of the lumen is involved. Richer, these are Madel's hernia, which is M type. Inguinal herniatomy, removal of the hernia sac, herniorrhaphy, repair of the hernia, hernioplasty by the mesh repair. What is Passin's Lichtenstein repair, shoulder repair. So inguinal hernia is strangulated, you have to go for emergency surgery and may require resection, symptomatic elective primary in this. Different types of laparoscopy, tap, total extraperitoneal tap is extraperitoneal tap is through peritoneum, and always it is above the peritoneum. These are the abdominal incision, this is Cocker's incision. You can see this is a rooftop incision, this is a midline incision, the gridiron incision, lens incision is done in the females. Appendix sign, Rosing signs, pain in the right iliac fossa when you compress the left side, obturate sign when you try to bend medial rotation, or sign when you stretch. Both sign is typically hyperesthesia of the right scapula. Murphy sign, person is catching the breath. Pancreatitis, Cullen sign, CU is umbilical, near the umbilicus. Great Turner size is blue discoloration of the skin in retroperitoneum. Abdominal retrograde plain contrast, plain X-ray, normal physiological phenomena. In this, you get gas in the diaphragm. Chiladity sign, where large bowel is impacted in between multiple air fluid levels. So this is about differential diagnosis of the small bowel obstruction, large bowel obstruction. On X-ray abdomen, you get a thumbprint sign. This is called a step ladder. This is thumbprinting, example of small. And this is loss of obstructions. You can see this is diameter, this is peripheral, this is central. Loops are in the central, this is peripheral, absent, multi-step lateral appearance absent. Contrast study, gastrography has to be done. What is abdomen compartment syndrome? Increase intra-abdominal pressure, normal value is 5 to 7 mm Hg. If it is increased to 12 to 20, changes more than 15 appears. It is measured by intravesical catheter. Cause may be surgical procedures. High index of suspicion of deteriorates less our urinary output, alkalosis, acidosis, and nasogastric aspirates. Then you have to gastric decomposition, improve the abdominal compliance. Drain has to be so wound adhesions. It can be subdivided into some factors which lead to increase in adhesions: old age, male gender, diabetes, smoking, all these. Operative factors, emergency surgery unless the operation is length of operation is more than 10 years, 6 hours. Wound infection, poor surgical techniques. If Jenkins rule is not used, post-operative factors is prolonged ventilation, poor tissue perfusion may lead to burst abdomen. It is defined as operative separation of the abdominal wall. 12% of the laparotomy cases, usually within after 6 days. Management is by analgesia, intravenous fluids, cover the wound with the dressings, correct the underlying cause, total parenteral nutrition has to be given. Wound state, the wound states are healthy, there is enough. Then there is some granulation tissue. You can see suturing of the deep tissue. When there is very bad condition, you have to apply vacuum extract devices. So these are the splenic trauma. Spleen is commonly injured organ. It is lying 9 to 11th rib, grade 1, 2, 3, 4. 1 is 10%, less than 10%, 1 centimeter, 10 to 15%, 1 to 3 centimeter deep, more than 50%, more than 3 centimeter deep. So any injury in presence of splenic vascular, the highlight here is the splenic trauma is conservative. Adult with hemodynamic stability or children, fast ultrasound is enough. Adult hemodynamic stable, CT scan has to be done. Small subcapsular hemata, conservative, minimal intra-abdominal blood, then it's conservative, no hilar disruption, conservative. Laparotomy with conservation if increase intra-abdominal fluid, blood. Moderate compromise, dissection less than 50. Resection is done, hilar is there, major blood vessels there. After splenectomy, there may be early and late complication, pancreatic fistula, prophylactic aspirin, platelet is more than used to begin, encapsulated pneumococcal infection has to be there.